Grand Rounds. I'm pleased to have Dr. Coates join us this morning for Grand Rounds. She is one of the organizers for the White Coats for Black Lives event that was on the Health Sciences campus a couple of months back. I found that event to be very moving, and at the end of it, went up and introduced myself. And I thought, first question that came to my mind was, what can I do to help? And the first answer that popped to my mind was this: we can provide a platform for education. And so in doing this, I asked Dr. Coates if she'd be willing to present, and together we're going to talk about maternal and neonatal outcomes and the disparities in outcomes. Our objectives are to recognize those factors leading to disparities in maternal morbidity and mortality, to recognize the contributing factors leading to disparities in neonatal outcome, and to identify innovations at the federal and state policy that can impact maternal and neonatal outcomes, as well as innovations in healthcare delivery that may positively impact those outcomes. Neither of us have any conflicts of interest to disclose. I put my little rabbit hole picture there in the corner solely for this purpose. There are many, many different routes you could go in this presentation. I would like to tell you that this is all inclusive and it captures all the different components of disparities in maternal and neonatal outcomes. It won't. It can't. We could talk for days and write books on the factors that lead to the disparities. So we're going to talk about some overview of things, and we're going to use some specific examples of things as well. Let me present to you Dr. Coates.
Good morning, everyone. I think that this is a perfect introduction slide because it shows where the U.S. stands compared to other countries as far as life expectancy at birth, which should surprise all of us because the U.S. performs poorly on most measures of health compared to other high-income countries, but we spend the most healthcare dollars compared to other high-income countries. But also, not only do we spend the most money, but we also have obvious disparities among different race and ethnic groups, and these vary by different states. And it's also true for all age and income groups. Now, what is maternal mortality? The WHO defines a maternal death as the death of a woman while pregnant or within 42 days of termination of pregnancy, irrespective of the duration and site of the pregnancy, from any cause related to or aggravated by the pregnancy or its management. The CDC expands that definition to include the death of women while pregnant or within 1 year instead of that 42 days of the end of pregnancy. I know we're all familiar with the social determinants of health, and if not, we should be, because these are all the non-medical factors that affect the health of the patients that we see in our office every day. These are often the factors that we can forget about, which can affect our patients' adherence to our medical recommendations. Those factors include food, community and social support, the healthcare system itself, economic stability, our patient's neighborhood and physical environment. Is it even safe to be able to come outside their home to even make it to their doctor's appointment? And then also their education, their health literacy. By addressing the factors within the social determinants of health, we are working to reduce overall health disparities within populations. The National Institutes of Health defines a health disparity population as one in which there is significant disparity in the overall rate of disease incidence, prevalence, morbidity or mortality in the specified population. What's interesting is that most studies document low educational achievement as the leading determinant of poor health outcomes because individuals who have lower educational achievement have higher risk for poor behaviors such as tobacco use, poor nutrition, and low physical activity. And we all know that those behaviors are associated with increased risk of chronic disease, but also these individuals will have decreased effectiveness and fewer resources to manage such diseases, and they'll have less access to healthcare and health-related resources. And Dr. Duncan will come back and address some more social determinants of health as we move on in our presentation. So one of the first things I learned, or I feel like is kind of taught to you when you are a public health student, is the top 10 major achievements within public health in the US. And this is within this decade, 2000 to 2010. And these are all things that we have made improvements in. And two of those listed and I highlighted is number 7 and number 8, and specifically number 7, healthier mothers and babies. And the reason why this was dedicated as one of the top achievements is because around this time we did see a reduction in number of infants who were born with neural tube defects, and we had expansion and screening for newborn metabolic as well as heritable disorders. But we all know that we still have work to do in these areas. One of the CDC Healthy People 2020 goals included improve the health and well-being of women, infants, children, and families, because we can't just stop at those goals from 2001 to 2010 because of the increase in maternal mortality, infant mortality rates that we see. Number 8 is really important, access to family planning and contraceptives, because many studies suggest that unintended pregnancy rates influence maternal mortality rates. According to the Guttmacher Institute, in 2011, nearly half, 45% of 6.1 million pregnancies were unintended. 27% of the women stated that it was incorrect timing. They wanted to get pregnant, but they weren't planning to get pregnant at that time. And 18% of the women stated pregnancies were unwanted. Unintended pregnancy rates are highest amongst low-income women, women of color, women between the ages of 18 and 24, cohabiting women, so women with partners, and women without a high school degree. Now, the outcomes of these pregnancies, 42% of unintended pregnancies ended in abortion, and 58% ended in birth within the year 2011. Now, looking at the overall state of mother's health in the United States, approximately 700 women die each year in the US due to pregnancy delivery complications. Over the past 28 years, the maternal mortality rates have increased by 26%. And with 700 women dying each year in the US, Black women have almost 4 times greater risk of death from pregnancy-related complications compared to white women. As we talked about earlier, infant mortality and maternal mortality has been an indicator of a country's health status. US, we don't do well compared to other high-income countries. And this led to the CDC conducting national pregnancy-related mortality surveillance to better understand the risk factors for and the causes of pregnancy-related death within the US. If you visit the CDC website, you will see findings are released regularly on the data that they find, but also CDC promotes not only their national pregnancy-related mortality surveillance, but also supporting maternal mortality review committees within each state, including the state of Kentucky, which I'll talk about a little bit later. This graph shows the trend of this increase in pregnancy-related mortality in the United States. In 1987, 7.2 deaths per 100,000 births. Now, up to 2016, there were 18.8 deaths per 100,000 births. So the CDC had initiated the pregnancy mortality surveillance system and implemented it, and it to be able to show this trend, and also for us to use our resources to be able to help reduce the trend in order to get our numbers back down or find the causes of the increased rates in maternal mortality. This is a graph that shows the most common causes of maternal mortality in 2011 to 2016. Almost half of the deaths in 2016 were caused by hemorrhage, cardiovascular and coronary conditions, cardiomyopathy, and infection. It is estimated that more than 60% of pregnancy-related deaths were preventable in 2016. As you can see, cardiovascular disease is one of the leading causes of maternal mortality, but there's also this 6% of pregnancy related deaths that the cause is unknown. And just my theory is that may be associated with more drug intoxication, but that's just the theory that I have. Now let's talk specifically about the racial ethnic disparities in maternal mortality. As we stated, Black women are dying at have rates of dying compared to white women, are dying at higher rates compared to white women, and Black women are more likely to die from complications such as bleeding, hypertension disorders, as well as cardiomyopathy. So a study in 2007 wanted to look at why is this happening. This study wanted to look at, is it because there's a difference in prevalence of a condition when comparing Black mothers to white mothers, or was there a difference in case fatality rates when comparing Black mothers to white mothers? So in this study, 5 conditions were assessed. Those conditions were preeclampsia, eclampsia, placental abruption, placenta previa, and postpartum hemorrhage. The study you wanted to look at those 5 conditions because they were able to extract that data from a national database. And those 5 conditions make up or account for about 26% of all the pregnancy related deaths. What they found was that they calculated the prevalence and case fatality rates for the above conditions in women who died from 1988 to 1999 using national databases from all the hospitals around the country. And for the 5 conditions that I mentioned, none of the prevalence rates calculated for each condition was statistically significant when comparing Black and white women, but the case fatality rates for all 5 conditions were significantly higher among Black women compared to white women. Black women had case fatality rates that were 2 to 3 times greater than white women. This study demonstrates that Black women had these higher case fatality rates in conditions even with similar underlying rates of the conditions compared to white women. When we look at the population of women who are getting pregnant and who are having babies, it's really important for us to understand maternal mortality rates and why it's affecting Black women more, because Black women are the women who we see in our offices most often because they are in 2013, it showed that nearly half of U.S. births were due to women of color. Also, 38% of the U.S. population are members of racial or ethnic minority groups. So it's really important for us to focus on the why is this happening so that we can reduce it amongst the women that we are working with. A study in 2011 by Krienga, it looked at hospitalization data across 7 states to identify disparities of severe maternal morbidity using 25 severe maternal morbidity indicators. And what this study found was the pregnancy-related mortality ratio was way higher in non-Hispanic Black women compared to white women, Hispanic women, and women of other races. So 38.9 per 100,000 live births for non-Hispanic Black women. A lot of studies go on to discuss if women enter prenatal care at an earlier time frame, would it help reduce maternal mortality rates? Because there's many studies that say women should have at least 4 prenatal care visits, or women who have at least 4 prenatal care visits have lower morbidity and mortality rates. But there's other studies that look at their entry into prenatal care, whether it's in the first trimester, second trimester, or third trimester, does that influence their risk of maternal morbidity or mortality? Many studies have evaluated if experiences of individual or group racism influences if a woman will enter into prenatal care. I found about 5 studies that supported this hypothesis, but I wanted to discuss the one study that did not support this hypothesis because I thought it was interesting. There was a study in Baltimore in 2008 that looked at African American women's entry into prenatal care and used semi-structured interviews to determine if their entry into prenatal care was influenced by their own individual experiences of racism versus the experiences of their family, friends, or loved ones if they knew of their loved ones having racial interactions or experiences of racism, if that affected when they entered prenatal care. And this was 872 African American women who were interviewed. They only used African American interviewers to help reduce any barrier to women opening up and having these conversations. They also created a racism and life experiences scale. And women were asked questions such as, how much have you personally experienced racism, racial prejudice, or discrimination during your lifetime during the past year? Or how has racism impacted the life experiences of people close to you? And what they found using multinomial logistic regression models was that women who denied racism, most specifically group experiences of racism, were more likely to enter the prenatal care during third trimester or to not have prenatal care at all, which is opposite from what they thought. They thought that if women denied racial interactions or racism with their providers, that they would enter into the healthcare system and prenatal care system earlier. And one of the conclusions that they made was that acknowledgement or denial that racism personally affected women was not statistically associated with timing of women when they begin prenatal care, but women are more likely to report that racism impacts the lives of their loved ones and acknowledge how it impacts them personally, which went against all the other studies that said that racial interactions with prenatal care providers negatively impacted women in their entry into prenatal care. This is a very busy slide. I'm not expecting you to read it, but one study performed a literature research and identified all of the studies that evaluated racial, ethnic disparities in health outcomes and recognized the outcomes conditions that influence maternal morbidity. And they created a list of examples of disparities in health outcomes and identified severe maternal morbidity indicators. And as you will look at a lot of these indicators, such as acute MI, renal failure, amniotic fluid embolism, cardiac monitoring, DIC, for all of those indicators, almost every study that they did the lit review showed that there was an increased risk among African American women. And when doing this lit research to prepare for this study, it's really interesting because a lot of how the ACOG as well as SMFM defines maternal morbidity and mortality, it fluctuates because they define it as pregnancy related or pregnancy associated outcomes. And so by not having this direct definition, this study sought to kind of look at some of the top causes of maternal morbidity and wanted to find all the studies that address those causes and all the study and also to evaluate what the study's outcomes were. And basically all the studies were saying the same things, that African American women have these high rates and all of these high risk complications. Factors that affect pregnancy and childbirth outcomes. There are patient level factors that influence maternal mortality rates. These patient level factors include certain races, ethnicities are more prone to certain diseases, such as African American women are more prone to sickle cell anemia. There's also the role of genetic variations, which can be complicated by environment interactions, and the role of epigenetics, which Dr. Duncan will also discuss a little later. Preconception health status is really important, but in our practice, we notice that women enter prenatal care later, which is affected by the 45% of women in their unattended pregnancy rates. Therefore, we have this limited time to identify and treat pre-pregnancy conditions. Also, age at time of pregnancy is important. Younger women, most likely less educated, can be a barrier for understanding medical conditions and their health status, as well as a barrier to access to health care. Older women, advanced maternal age, have higher rates of pregnancy conditions, such as preeclampsia, gestational diabetes. So they have higher risk for maternal morbidity, which is associated with mortality. But there's also healthcare system level factors that affect pregnancy outcomes. Uninsured or underinsured women have the most difficulty accessing healthcare resources. But there's broader structural disparities, such as unequal education opportunities and economic disparities with unequal job opportunities when comparing Black Americans to white Americans, and that negatively influences the social economic status of the individual. But there's also practitioner level factors that affect maternal mortality. Our own stereotypes and implicit bias contribute to the health disparities of our patients that we care for every day. There are many documented examples of biases of how practitioners won't recommend LARCs for certain women who are at high risk for unattended pregnancies. And then we also have to remember this culturally derived mistrust of the healthcare system from events such as coercive sterilization of poor women of color. And we also have to take a trip down memory lane in general. We could stop at slavery, where we have this group of oppressed individuals for over 400 years who are distrusting of the medical system. We also have examples documented throughout history, such as Dr. Sims, who was known to practice surgical techniques on enslaved Black women without anesthesia. There were sterilization laws that targeted individuals with mental illness. We all should be very familiar with the 40-year Tuskegee syphilis experiment that purposely targeted Black men and left them untreated with syphilis even when there was treatment available. And then there's the story of Miss Henrietta Lacks, 31-year-old woman who died of cervical cancer, and her HeLa cell line went on to make multiple white companies, white scientists money as they were used to study drugs, hormones, viruses, vaccines, and her family never gave consent for this. And her family lived in poverty while everyone else profited off of her cell line. So these are all things we should remember why the African American community is so distrusting of the white medical community when the white medical doctors make up 60% of the medical community. All right, as I wrap up before we go on to infant mortality with Dr. Duncan, how are we doing in Kentucky? So we talked about the maternal mortality review committee. We had a maternal mortality review committee for many years in Kentucky, but due to resources, it kind of fell off, but it came back in 2017 very strong to look in depth and review the 20 deaths of women throughout the state of Kentucky. As illustrated in this model, you can see that the number of deaths have increased over the years. One of the first things that the Maternal Mortality Review Committee wanted to look at is why was the year 2014 so different compared to the other years? And so they did go back and look at the birth certificates and the deaths of women during that year, and there were no explanations for the differences found. And so that was just an interesting finding. This graph goes on to show the top causes of maternal mortality in the state of Kentucky. As you can see, the leading cause being drug intoxication and overdose. That 31% is thought to be actually higher because a lot of the drug intoxication overdose are marked as cardiovascular and coronary conditions, although the leading cause was likely IV drug use. The disparities in Kentucky do vary by geography, race, and access to care. Kentucky's population is 87.6% white, 8.4% black, and 3.7% Hispanic. The number of deaths of Black or Hispanic women in Kentucky is too small to form conclusions at this time about racial disparities, but death certificates show maternal deaths appear to be higher among Black women in two of the largest urban areas, such as Lexington and Louisville, but we don't have enough data to make those big conclusions at this time.
Thank you, Dr. Coates. This slide looks at Black and white disparities in birth outcomes in the United States from an article from Seminars in Perinatology. The one notable thing is the infant mortality rate is really a marker of maternal and child health. Not only is it a marker, but it's symbolic of the benchmark of the society's overall health. Using this standard, the United States deficient with the following striking characteristics. The infant mortality rate's high compared to other developed nations, and African American infants have a 2.2-fold greater mortality rate than white infants. Disorders related to short gestation, that is less than 37 weeks, and low birth weight, less than 2,500 grams, are leading cause of death for all African American infants, whereas congenital malformations are leading cause of death for white babies. African American and white mortality rate ratios range from 1.2 for congenital malformations to 3.5 for disorders related to short gestation. We know that short gestation or prematurity is linked with low birth weight, and particularly with very low birth weight infant, that is those infants less than 1,500 grams. Importantly, low birth weight is a strong determinant of first-year mortality and contributes to racial disparity in the infant mortality rates. It's well known that young maternal age, low educational attainment, low income, unmarried marital status, short pregnancy interval, Dr. Schickler, health eroding personal behaviors such as cigarette smoking, alcohol intake, illicit drug use, and inadequate prenatal care are well documented risk factors for low birth weight. Numerous studies have found that the disparities in the incidence of low birth weight and very low birth weight are not only persistent, but actually widen as a woman's socio-demographic status, medical status, and behavioral status decline. College-educated African-American women who receive adequate prenatal care still have more than a twofold greater low birth weight rate than college-educated white women who receive adequate prenatal care. Part of the theory behind why this might be has to deal with life course factors. That life course factors influence pregnancy outcome using two different mechanisms. The first being early life or fetal programming of reproductive potential and cumulative wear and tear, best described as a hypothesis called weathering. For both of those pathways, the key to understanding that mechanism is stress and the body's response to it. So there's been an outpouring of studies related to programming during fetal life affecting health status as an adult. The easy example is the Barker hypothesis, where adverse nutrition early in fetal life results in metabolic syndrome for adults. It's been shown that when women experience stress during their pregnancies, the brain and placenta secrete corticotropin-releasing hormone. This hormone can pass into fetal circulation during critical periods of neuroendocrine and hypothalamic pituitary adrenal axis development, and ultimately can lead to a female infant with a higher stress reactivity later in life. That is, they'll secrete an increased amount of CRH and cortisol when exposed to stress, and subsequently place that woman at a greater risk for preterm labor when she becomes pregnant 20 to 30 years later. One aspect of this heightened stress reactivity is the inability to terminate the cortisol stress response after the stress is passed, resulting in a chronic exposure of body systems to elevated stress hormones. This is referred to as the allostatic load, which is what this graph shows above. Increased allostatic load with all the associated health risks has been shown to correlate with lower social class and with being African American, even in the absence of poverty. Racial discriminations of social contexts that African American women have to navigate throughout their lives. And there's certainly an expanding amount of literature that suggests that an African American's exposure to interpersonal racial discrimination is a risk factor for poor pregnancy outcomes. This underlying mechanism appears to be related to stress. The physiologic responses to chronic exposure to stress can accumulate over time, leading to enhanced inflammatory response, compromised fetal development, and adverse pregnancy outcomes. We're very aware of the role of epigenetics. Probably one of the best examples ultimately ends up being the role of epigenetics and opioid abuse and potential outcomes and recurrence as we go through generational lines. Epigenetics provides a biological mechanism for the appearance of accumulation of environmental exposures throughout the lifetime. Here's a study that Haggerty and his colleagues performed that investigated the association between birth weight, length, placental weight, and duration of gestation and 4 DNA methylation gene variants, as well as methylation of line 1 and 3 imprinted genes. They were able to show that there was an association between different alleles and different gene methylations associated with birth weight, birth length, placenta weights, reduced risk of requiring neonatal care. So ultimately, this maternal environment can influence multiple generations, compounding the effects of racial disparities. Environmental influences are not limited to the person with direct exposure, but can be transmitted to subsequent generations. So we think that at least 3 generations can be directly affected. So environmental contributions to racial disparities in birth outcomes of multiple generations may be especially true for African Americans who've endured environments of discrimination and chronic stress for generations. This is one example of epigenetic effect. We know that nutritional environment affects birth outcomes and contribute to racial disparities. Folate is considered the major source of the one carbon group used to methylate DNA. We know that insufficient maternal folate is associated with low birth weight, intrauterine growth restriction, and preterm birth. A study investigating folate reported that white women were more likely to have increased folic acid supplementation before and during pregnancy compared with Black women. Similarly, folic acid and multivitamin supplementation may decrease the risk of preterm birth and increase birth weight, especially in Blacks. So differences in dietary folate can alter epigenetics and may subsequently contribute to racial disparities and adverse birth outcomes. Shifting to the weathering hypothesis, weathering talks about the deterioration in reproductive health status over the childbearing years among African American women. The weathering hypothesis conceptualizes the physical consequences of social inequality on the female reproductive outcome. We know that young and advanced maternal age are well-described risk factor for low birth weight among white women. However, if you look at the curve for African American women, instead of seeing this U-shaped or J-shaped curve, it's a monotonic line that shows a risk for infant with low birth weight for African American women grows with advancing age. This starts to increase in their 20s and 30s, which is the prime time for childbearing year. Neighborhood poverty may be one of the things that drives the weathering phenomenon among urban African American women and contributes to the racial disparity in infant birth weight. In a recent study, weathering pattern of maternal age and infant birth weight was limited to African American women with lifelong residents in low-income urban neighborhoods. So does neighborhood really play a role in weathering? Infant low birth weight rates did not increase with maternal age among African American women with lifelong residence in high-income neighborhoods. Moreover, African American women in their early 30s with lifelong residence in high-income neighborhoods had a low birth weight rate, one half of that of African American women in their early 30s with lifelong residence in low-income neighborhoods. We know that racism exists. We know that it's embedded within social institutions, and those social institutions produces disparities in life conditions with threatened health because they provide the infrastructure through which social resources are distributed. We consider things such as just differential allocation of financial resources and residential segregation. Residential segregation is a distinguishing organizational characteristic of American life. And there's an extensive body of literature that shows that neighborhood poverty during adulthood is an independent risk factor for the delivery of a low birth weight infant. Beyond individual factors, community factors are strongly associated with perinatal outcomes, thought to affect outcomes through neighborhood disadvantages such as concentrated poverty, environmental stressors, limited access to health services. Racial segregation has been shown to be associated with decreased birth weight, preterm birth, and infant mortality among African American. There's a growing interest on the effects of the built environment on birth outcomes. Beyond racial segregation, measures such as housing damage, property damage, home vacancy, crime, percentage of home rentals have all been shown to affect the risk of preterm birth. Features of the physical environment such as pollution and toxin exposure and air quality are beginning to be studied in a relationship to birth outcome. Finally, violent crime is increasingly recognized as an element of the neighborhood environment, not commonly investigated, and has been shown to be associated with low birth weight and preterm birth. I'm sorry, I will butcher this investigator's name, Jirescu. Performed this study. It was designed to examine 4 different concepts: the relationship among objective and perceived indicators of neighborhood environment, racial discrimination, psychological distress, and gestational age at birth, to determine if neighborhood environment and racial discrimination predicted psychological distress, to determine if neighborhood environment, racial discrimination, and psychological distress predicted preterm birth, and determine if psychological distress mediated the effects of neighborhood environment and racial discrimination on preterm birth. This was performed at a postpartum unit in the medical center in Chicago, with half of the participants being mothers who delivered preterm, and the other half being mothers who delivered at term. Let's take a look, though, and see what they studied. You should be horrified by this slide. If you're not horrified by this slide, take a second and look at this slide a little closer. These are the aspects that they examined. Physical disorders included vacant housing, vacant lots, and vandalism. Social disorders, activities involving people, such as drug dealing, prostitution, and gangs. Violent crimes, such as homicides and sexual assaults. I would venture to say that probably none of us live in a neighborhood where these are necessarily high rate of activities or a high rate of environment that surrounds us. These are the things that the impoverished, that the African American woman has to deal with on a regular basis. So let's go back to our study. Ultimately, women who reported higher levels of perceived social and physical disorder and perceived crime also reported higher levels of psychological distress. Women who reported more experiences of racial discrimination also had higher levels of psychological distress. Objective social disorders and perceived crime predicted psychological distress. Objective physical disorders and psychological distress predicted preterm birth. Therefore, psychological distress mediated the effect of objective social disorders and perceived crime on preterm birth, and the model ultimately explained 51% of the overall variance. Let's move on to another model. This model was proposed by Andrews and a group who wrote a commentary in Pediatric Research and suggested an overlap of lower quality care, socioeconomic disadvantage, and increased risk can affect the health and well-being of preterm infants and their families. The question is there really a difference in the quality of care? Well, to answer that question, we know that quality of care is a crucial and potentially modifiable factor and contributes to disparities as one of the causal pathways by which racism, segregation, and inequality adversely affect outcomes. We know that there are structural characteristics, organizational models, and clinical processes that can lead to lower quality of care. I'm going to show you four different studies that looks at quality of care. This first study was done by Howell in 2008. It sought to determine whether differences in hospitals in which Black and white infants are born contribute to Black and white disparities and very low birth weight and neonatal mortality rates in New York City. The data for this study is nearly 20 years old. And so the first question you got to ask me is why are you showing me a study that's 20 years old? Wait for it, because I'm going to show you something else in a minute. In this study, they showed that risk-adjusted mortality rates in New York City ranged from 9.6 to 27.2 deaths per 1,000 births. This figure shows the cumulative distribution of births among hospitals ranked from the lowest on the left to the highest mortality ratios on the right. You'll see that the mortality ratios differed for Black and white mothers. You'll see that very low birth weight babies were more likely to be born in the lower mortality tertile if they were white babies. You will see compared to Black babies who are more likely to be born in the highest mortality tertile. I don't know if the pointer shows up on this or not, but nearly 50% of white babies are born in this lower mortality tertile, whereas only about 29% of African American babies are. So they pushed this study a little bit further and they said, what if we redistributed everything so that all babies, Black and white babies, were born proportionally at the different levels of hospitals and got the same level of care? What they determined is if you did that in equal proportions, that you would reduce racial disparity by almost 35%. Now, Here's why I showed that study. Because Hal did a follow-up study some years later, and they wanted to see if the patterns of care by race and ethnicity were still apparent, whether hospital performance varied for seriously very preterm morbidities and mortality, and the extent to which variations in hospital performance contributed to disparities in the care for non-Hispanic Black, Hispanic, and non-Hispanic white very preterm babies. Ultimately, they found that the risk standardization, mortality, and morbidity rates were twice as great for very preterm births born in hospitals with the highest morbidity and mortality tertiles as for those born in the lowest morbidity and mortality tertile. Black and Hispanic very preterm births were more likely than white very preterm births to be born in hospitals with the highest morbidity and mortality tertile. The largest portion of the explained disparities can be attributed to the differences in infant health risk among Black, Hispanic, and white very preterm births. 40% was continued to be explained by birth hospitals. So despite more than 10 years of quality improvements, poor performance at hospital where Black and Hispanic mothers deliver is an important and likely a modifiable cause of racial and ethnic disparities in neonatal outcomes. So if it works in New York, is it the same elsewhere? This study was performed in California. The California Perinatal Quality Collaborative is probably the strongest collaborative in the United States. They performed a study using a measure baby monitor. It has 9 process and 3 other outcome measures, and they put a score to it. Ultimately, what they found was this in the California hospitals, that there's a large racial and ethnic difference in quality between and within neonatal ICUs. The quality deficit among disadvantaged population is concentrated on modifiable measures of quality, and it's more useful to look at stratification rather than risk adjustments. Wide differences among NICUs still persist. So if it works at New York and California, does it work nationally? The same group, who are prolific writers, Dr. Hobart and Dr. Lee are the 2 names that come to mind, looked at Vermont-Oxford data. This studied 743 NICUs and included almost 118,000 Black, Hispanic, and white infants born between 400 and 1,500 grams and 22 to 29 weeks gestation. They plotted this and created something called a Lorenz curve. I'd have to have a statistician explain it in depth to you, but here's the bottom line. This diagonal line that's dotted shows the reference, which is non-Hispanic whites. And anything below that line, the blue, the black, the orange, representing Asian, Hispanic, and Black babies, shows that there was segregation by race and ethnicity into neonatal intensive care units throughout the United States. They carried this a step further and looked for inequalities of care. Again, the reference is white babies, that dotted line, diagonal line. Anything above it suggested actually there was better quality care. That's in the Hispanic and Asian group. And in the black line, the Black African American babies, shows that they received a lower quality of care. Why in the world would that be? In all the work that we have done, why do we think that's a possibility? Well, here's what occurs, or one example of what occurs. This is a study performed by Lake that looked at nursing staffing. What makes the poorest performing hospitals different? They looked at a retrospective 8,252 babies in Vermont-Oxford units. The principal findings were that very low birth weights born in high Black concentration hospitals had higher rates of infection and discharge without breast milk than very low birth weights born in low Black concentration hospitals. You see, they've separated these hospitals out by low Black concentration, less than 11%, to high Black, greater than 31%. What made these hospitals a little bit different? Nursing understaffing was higher. Practice environments were worse in high Black compared to low Black hospitals. Relative to national guidelines, sample NICUs were understaffed on average to 0.18 nurse per NICU. Understaffing was greater in high Black hospitals than in low Black hospitals. NICU nursing features accounted for 1/3 to 1/2 of hospital-level health disparities. The two principal institutional factors likely to be financial constraints and poor overall management. Are there other markers of quality of care? Absolutely. A different study also performed by Lake looked at variation across NICUs and missed nursing care and disproportionately Black and non-Black serving hospitals and the factors associated with missed nursing care. Principal findings again showed that the patient to nurse ratio was significantly higher in high Black hospitals. Nurses in high Black NICUs missed nearly 50% more nursing care than in low Black NICUs. Lower nursing staffing, that is, an additional patient per nurse, significantly increased the odds of missed care, while better practice environment helped decrease those odds. What type of care was missed? Well, here's what was missed. Thankfully, the biggest thing that was missed was care plans, teaching and counseling, comfort and talk. Well, that's not very good. Thankfully, what seemed to be the least thing of missed was actually acute care. The principal driver behind this was insufficient staffing. The other thing to note about insufficient staffing is it's a principal driver of nurse burnout and turnover. So as managers, we should advocate for higher staffing levels and work to improve their unit environment. We're starting to run short of time, so I'm going to buzz through a couple of slides real quickly. This looked at patient care experiences among racially and ethnically diverse mothers whose baby required a NICU stay. I want to point out the last part of this slide where the differences among racial and ethnic groups. Descriptions of explicit discrimination were rare. Black and Latina women described receiving or observing disparaging treatment from hospital staff for speaking a foreign language. Black women reported a few instances of poor and ineffective communication from healthcare providers, which exasperated the stress of pregnancy complications, and some Black mothers felt ignored or dismissed by providers. Here again, we find some structural issues. Insurance coverage and provider selections marked very markedly by race and ethnicity. Black and Latina mothers are mostly insured by Medicaid and typically choose the hospital rather than the specific provider. So if these things haven't convinced you that there are disparities that exist, let me show you two last things. First thing is does socioeconomic status modify the association between preterm birth and a child's early cognitive ability and kindergarten achievement? The bottom line was this, is if you looked at children who were preterm, they had lower cognitive abilities, kindergarten mathematics scores, and kindergarten reading scores. If you looked at socioeconomic status, you found the same thing. If you looked at the combination of the two, prematurity and lower socioeconomic status, they had the poorest performance on all three outcomes and are considered a high-risk group. This continues out through the 8th grade, where we think about prematurity and socioeconomic status, and we know that if you have an educated, higher socioeconomic status, ultimately you have better outcomes. So are we seeing any progress? This study was performed that looked at county level data to see whether low birth weight rates in a Black population and a white population were any different. The bottom line ends up being this. Each county's progress was looked at, and only 4 counties out of 408 were showing progress, decreased Black low birth weight rates, white low birth weight rates. 1%. They said the communities are demonstrating more equitable outcomes is a possibility. I thought 1% was pretty optimistic. We're running short of time. Dr. Coates asked me to review this. These are recommendations to address racial and ethnic disparities. The first thing is to talk about disparities. Talk about it within your own department, within your own unit. Review your data on quality improvement on a regular basis to acknowledge that the disparities exist. Recognize the biases, your own biases, which can influence health outcomes. This includes more than acknowledging bias or having implicit bias training. This involves understanding other cultures and patients' reluctance to care. It involves more work on our end in order to get that done. We can offer anonymous surveys, ask them how they feel more comfortable and included in care, and if they have an experience of racism while they were in your office or in your unit. We need to collect clinical data that shows how women are doing in our practice compared with other groups. Also, talk to your patients, talk to your mothers. Consider performing research projects with structured interviews and focus groups. We know that education matters. Educate, provide material that supports the women you're serving. It should include images of people who resemble them and written in a way that they can understand. Diversity matters. Only 5% of the physician workforce is African American, 5.8% Hispanic. Representation matters to patients when you don't look like them. Many studies have demonstrated it improves health outcomes. Black and white patients perceive personal similarities and increase patient-physician trust when they had a physician who was of the same race. Finally, we want to support, assist, and recruit minorities going into OBGYN, pediatrics, neonatology, and academic and community healthcare fields. Are there other things going on? Certainly at a national level, we want some of the health policies to focus on non-health sectors. For example, nutrition programs and policies to promote health by supporting healthier corner stores in low-income communities, farm-to-school programs, community and school gardens, broaden efforts to support production and consumption of healthy foods. Provision of early childhood education helps reduce achievement gaps, improves the health of low-income students, and promotes health equity. Affects health. It engages diverse partners and stakeholders to work together to promote health, equity, and sustainability. There are federal and state initiatives through the Center of Medicare and Medicaid Innovation, which established a new accountable health community model that focused on connecting Medicaid and Medicare beneficiaries with community services, not only connecting, but navigating as well as providing some of those services. There's been reform of payment systems and delivery systems that links on healthcare and social needs. Some state Medicaid programs are supporting providers focused on social determinants through this delivery system reform incentive payment initiatives. Some states are providing housing and employment supports. Medicaid managed care organizations are increasingly engaging in activities to address social determinants of health. And finally, as providers, nonprofit hospitals are required to conduct a community health needs assessment once every 3 years. Some providers have adopted screening tools within their own practices. This is probably one of the last things that I'm going to show. This was a webinar that was done by the Vermont Oxford Network. They came up with 69 individual points considered as follow-through points. These are the broad headers that they described: promoting a culture of equity, identifying social risk of families and providing interventions to prevent and mitigate those risks, including that transition to home and maintaining support throughout infancy, developing robust QI efforts to ensure equitable, high-quality care, and to advocate for social justice at the local, state, and national level. And of course, you know, I couldn't do one of these lectures without referring back to Dr. Andrews. This is still framed in my office, that we fully realize that the level of civilization attained by any society will be determined by the attention it's paid to the welfare of its infants and children. Sorry to have run a few minutes over. Thank you so much for coming and appreciate your attention.
We will take any questions for the presenters now.
Answering Dr. Schultz's question about data suggest disparity of outcomes within individual NICUs. Yes, there are. That is part of what that and I'm sorry, we kind of got crunched for time. There's always so much stuff to present, but that's part of what that study that had the Lorenz curve showed, that there are some disparities of individual outcomes.
All right, thank you for that, Dr. Coates and Dr. Duncan. If anyone has any further questions, please reach out to them via email. We'll conclude the presentation at this time.
Thank you.
Thank you.